So, good evening, everyone. A very warm welcome to today's Academy's demo session. Thank you all for taking time to join us. We are delighted to have such a diverse audience with us today. Today's topic is Mosaicism in pre-implantation genetic testing for aneuploidies, a biological truth or technological artifact. Mosaicism remains one of the most fascinating and debated topic in reproductive genetics. Despite major advances in embryo testing technologies, the question remains regarding the biological significance of mosaic finding, their clinical relevance, laboratory interpretation, and how these results should be incorporated into the patient counseling and embryo selection decisions. Today's session aims to explore these important questions while also providing a glimpse into the type of educational content and discussion available through our Fertilis Academy. Before starting the session, we would just like to also briefly introduce the Academy. That Fertilis Academy is dedicated to advanced education in reproductive genetics, assisted reproductive medicine, embryology, genetic counseling, and precision medicine, reproductive medicine, with a mission to provide evidence-based, practical, and clinical relevant learning opportunities that help bridge the gap between rapidly evolving science and everyday clinical practice. So today's session serve as a demonstration of knowledge and interactive nature of our educational offerings. It is now my pleasure to introduce speaker for today's session, uh, Dr. Sarpreet. Can you just put your slide on a final like screen?
Yeah, Dr. Rajni, just give me a second.
Yeah.
Can you see the slides now?
Yes. 1 second. Yes. So, Dr. Sarpreet is a renowned embryologist. He's IFS Indian Fertility Society and ASHRAE certified senior clinical embryologist. He is MD from prestigious institute, All India Institute of Medical Sciences, New Delhi. Dr. Sarpreet is currently heading clinical embryology and andrology at Artemis Health Institute since year 2009. He's also chairing clinical embryology team unit of Indian Fertility Society for year 2024 to 2028. Dr. Sarpreet is also a director at Fertilis Academy, which provide online and hand-on teaching in reproductive medicine across the globe. Dr. Sarpreet's area of interest are cryobiology, male infertility, and sexual health. He has many prestigious awards in his honor. He has received a Champion of ISAR Award at ISAR Conference in 2020, Best Convener Award for SIG on Clinical Embryology at Fertivision 2019, Best SIG Applied Genetic Award at Fertivision 2020-2021, IFS Achievers Award at Fertivision 2022, and Appreciation Award at Fertivision 2023. Thank you, Dr. Sarpreet, for joining us today. The stage is here, and you can just start your presentation now.
Thank you, Dr. Rajni, for that warm introduction. And indeed, it's a pleasure to have you as a moderator because you are a real stalwart in the field of genetics and uh, Dr. Fiona. So I'll start the presentation now. The topic for the day is mosaicism in PGTA, that is pre-implantation genetic testing aneuploidy. Is it a biological truth or a technical or technological artifact? So we are going to discuss about mosaicism, its incidence, its prevalence, its reasons, and is it a technical artifact? I mean, or how does it influence embryo selection? Everything will be covered. What Dr. Igbilo also mentioned some points. So I'm going to proceed a little slowly, and then let us try to cover the maximum today. So before I move on to mosaicism, I'd like to introduce the concept of aneuploidy, that is a gain or loss of whole or large segments of chromosomes. So most chromosomal aneuploidies are not compatible with life except a few, which we don't need to go in details. So this is about aneuploidy, that is pre-implantation genetic testing for aneuploidies is done primarily for these reasons, to check for aneuploidies, whether they're segmental or whole that's a variant. The first IVF was Louis Brown she was born on 25th July 1978. All of you know that. And the success rates have always been dwindling between 20%, some people claim 60%, 70%, but generally they are ranging between 35 to 45% in most of the labs. And morphology of embryos is obviously not a very good indicator, and we need to supplement it with other things such as genetic testing, pre-implantation genetic testing, and to rule out things, phenomena like aneuploidies and structural rearrangements and monogenic diseases. So with that concept, we are going to start this topic, and also would like to highlight that ICSI has got a very high aneuploidy rate, especially if it's a fertile male sample. So as age increases, the aneuploidy also increases and thereby decreasing the implantation rates. So that is the primary reason why we need to check for aneuploidies through pre-PGT-A. And incidence of aneuploidy, if you look at the incidence of aneuploidy, more than 50% of pre-implantation embryos are aneuploid and they go on to increase with age. The aneuploidy rate in human oocytes is 20 to 30%. And if you take the example of a woman over 40 years of age, it goes up to 80%. This is all official data by American studies. So that just necessitating how important it is to check for genetic anomalies, especially aneuploidies. The indications have always been advanced maternal age, repeated implantation failure, severe male factor, previous pregnancy with chromosomal abnormalities, and repeated miscarriages. These have been the indications for pre-implantation genetic testing aneuploidy. But life is not that simple. PGTA is plagued by certain limitations, and today we are going to understand the science, the limitations, and the clinical implications behind mosaicism in PGTA. So, what is mosaicism? As Dr. Iguilo said, you have to explain it right from the baseline. So, I'm going to start right from the baseline. Chromosomal mosaicism has been defined as the presence of two or more cell lines with different genotypes in an individual sample. So, presence of two or more genetically distinct cell lines arising from a single zygote. That's mosaicism. If I have to describe it numerically, then normal karyotype is 46XX or XY, whereas aneuploid will be gain of a chromosome or loss of a chromosome. So it is 47. Say there is an extra 21st chromosome, so I'll write it as plus 21. Whereas the same thing in a mosaic embryo will be written, mosaic individual or embryo will be written as 46XX. So some cell lines represent 46XX, which is a normal cell line, whereas some cell lines are 47 plus 21, that is an aneuploid cell line. So this is the example of how mosaicism is represented. So the key message here is that mosaicism is a post-zygotic event. So you'll understand this last line better in a few slides from now. Now the question is, how common is mosaicism? Should we bother about mosaicism? In natural pregnancies, mosaicism ranges between 1 to 2%, whereas embryonic mosaicism is almost 15 to 30%. If you look at the reported incidence, it has been shown to vary from one technology to other technology. Whereas RSEGHS reports a mosaicism mosaic rate of 3 to 5%, NGS or next generation sequencing Whereas RSEGH reports a mosaic rate of 3 to 5%. NGS, which is the technology which is most commonly used for embryos nowadays, which is next generation sequencing, it reports a mosaic rate of 5 to 25%. So almost 5 times higher. The question is, are we over-reporting mosaicism or has mosaicism increased? So we'll talk about the sensitivity, the specificity of mosaicism reporting, whether it is actually false positive. Are we losing on embryos because of over-reporting of mosaicism? Is it causing more harm than good? So everything will be touched upon briefly in the next few slides. So potential sources of mosaicism always have been biological, that is mitotic distinction, anaphase leaks, chromosomal breakage, or it can be technical, that is whole genome amplification bias, NGS noise, sampling errors, contamination, etc. Or it can be lab induced. This is a big question mark whether actually lab can induce mosaicism or not. But if you look at the primary reasons, it can be culture stress, temperature fluctuations, Anything in lab which results in some biological rearrangement will lead to mosaicism. pH instability, oxidative stress, laser manipulation, biopsy trauma. We'll cover each aspect in few slides from now. So first of all, we'll address the biological aspects. So if you look at the if you look at the just one second. This is, yeah. So if you look at the mitotic versus meiotic errors, if you look at this figure, that top left represents that there is no error. It's a normal fertilization of euploid gametes and error-free progression of meiosis 2 and embryonic mitosis. So there is no aneuploidy. All cells are euploid. If you look at the second slide, the one in pink, meiotic error. Meiotic error, any error in the meiosis will render gametes homogeneously euploid or aneuploid. I mean, an error will lead to aneuploidy. And this whole embryo aneuploidy is generally not compatible with life. That is non-viable. Whereas a mitotic error which occurs post-fertilization, the first slide said that it's a post-zygotic error. It happens post-fertilization, then it's a post-zygotic error, and any error in mitosis here will lead to mosaic aneuploidy. That is, some cells represented in the figure as blue will be euploid, and one in red will be aneuploid. And on subsequent division, there's some cells will some blasters some cells will have more number of euploid cells, whereas some embryos will have more number of euploid and less number of aneuploid, and some will have more aneuploid and more and less number of euploid, depending on whether it's a single chromosomal loss, a single chromosomal gain, or it will lead to complex mosaic aneuploidy. I think things are clear till now. The origin of mosaicism, the incidence, the prevalence, we've all discussed. So I hope things are clear now. I need some response from you. Anybody has any issues till now? Because this is the basic slide. So errors in mitosis during embryonic cell divisions leads to a mixture of aneuploid and euploid cells. And mitotic aneuploidies are much more common compared to meiotic aneuploidies. And mitotic errors are more likely to self-correct. This is a very, very important statement. I want you to take a picture of this slide, because mitotic errors are more likely to self-correct. And this is a beautiful slide. It forms the basis of how the mosaicism is developing and how it is presenting as well. So kindly take a picture. I'm moving on to the next slide now. So if you look at the distribution of aneuploid cells in a blastocyst, so look at the first top left where my arrow is pointing. Look at the top left blastocyst. In this, the inner cell mass is red, that is aneuploid, whereas outer cell mass is blue, which is euploid. So when you take a biopsy from outer cell mass, obviously you can't go near the inner cell mass. When you take a biopsy from outer cell mass, it is misreported as a normal embryo. Now take the opposite case. We have got all aneuploid trophectoderm cells and inner cell mass is euploid. And when you take the biopsy from outer cell mass, it is again misreported as a aneuploid embryo, whereas the inner cell mass is absolutely normal, which is going to form the fetus. Now comes the case of trophectoderm mosaic. If the trophectoderm or the outer cell mass is a mosaic one, then depending on the site from where you're taking the biopsy, it can either give you take the example of this embryo. It can, if you take the biopsy from these two cells, it will be reported normal. These two cells, abnormal. A clump of these mixture of these cells, it will be reported as a mosaic embryo. Now take the example of ICM mosaic. That is, ICM is mosaic, trophectoderm is normal. So this will be reported as normal embryo, whereas it's a mosaic embryo. So it depends on the site of biopsy and the discordance between inner cell mass and outer cell mass. They might have different compositions. They might be purely aneuploid, purely euploid, or purely mosaics. And same is the case with the trophectoderm cells. It can be either euploid, aneuploid, or mosaic. And in that case, depending on the site of biopsy, the results will be reported. And generally, we take around 5 to 8 cells for an embryonic biopsy. If we go beyond that, we have chances of, and there is a chance of damaging the embryo. This is another figure representing the same previous slide. I found it quite interesting, so I included this in the presentation. So this again says that this is a mosaic inner cell mass, and depending on the site of biopsy, the results can be either accurate or they can be inaccurate. So this is also inner cell mass is absolutely euploid, and then again, it all depends on the site of biopsy from trophectoderm cells. So these figures represent different conditions in which reports can be non-representative of the inner cell mass composition. That is discordance. Again, even if you are detecting mosaicism, then the percentage of mosaicism is very important. Generally, a binary generally a binary method is followed. Anything which is less than 50% mosaic is considered euploid and is transferred. Anything more than 50% mosaicism is usually considered aneuploid and is discarded. So now, how do the results change depending on the site of biopsy? Suppose, so you take the case of this embryo. Now, in this embryo, there are 10 cells in the inner cell mass, and 6 are blue, that is euploid, and 4 are aneuploid, that is red. So it is 60% mosaic. Now, trophectoderm cells are not as nicely distributed as in the inner cell mass. And then, depending on the site of biopsy, either I can pick 1 aneuploid and 4 euploid, which will lead to a 20% euploidy rate, or I can pick 3, 3 aneuploid and 2 normal cells, euploid cells, which will lead to a 20 to 80% or 60% mosaicism rate. Or if I end up picking 5 cells which are all aneuploid, then this will lead to aneuploid rate. So that is how things differ. The site of biopsy, so there's a lot of discordance between inner cell mass and outer cell mass, plus the site of biopsy also can influence the results. So this is the biological reason why mosaicism is reported and how can it influence the final outcome. Another couple of aspects I would like to bring out here. The exact number, see, the all the mosaicism and all the results are calculated mathematically. Number of normal cells upon number of abnormal cells upon number of normal cells. So now you have analyzed some cells, and the exact number of cells in a trophectoderm biopsy is never known. Once I've biopsied, anybody who has done a biopsy or seen a biopsy, generally we take cells and we report it as a 6 to 8 cells, 5 to 9 cells, 5 to 6 cells. We can never count the number of cells. So the denominator is never clear. So when you don't have the denominator clear, it is very difficult to give out percentages. And also every trophectoderm biopsy damages individual cells and also cells which are in the neighborhood. This causes spillage of DNA and contamination of neighboring cells. Again, this is influencing the percentage of aneuploid DNA, which can never be accurately determined. So if the cells, I've taken 6 cells and damaged 2 cells which are next to the 6 cells, so that DNA will also leak and that DNA will also contribute to the final outcome. So these are the challenges which we face and which we are not able to avoid 100%. So now coming to discordance between trophectoderm and inner cell mass, I've shown you this figure, and there is discordance, and it is said that trophectoderm and inner cell mass, the discordant mosaicism rate is almost 3 to 4%, which is thankfully less. If it was 50%, then this technology won't even exist. So that is why you should offer the patient pre-cycle and post-cycle genetic counseling, explaining them everything and informing them of the limited information of transferring mosaic embryos. You know, there are risks associated and you should explain it to them. Abnormal sense may be collected in an otherwise euploid embryo and vice versa. It is inevitable that some embryos will be discarded because, because of this discordance, some embryos will be normal by virtue of inner cell mass, but may not be reported normal because the biopsy is being taken from the outer cell mass, and their normal image will be discarded. So anything which is false positive will be discarded, and this leads to overall decrease in the cumulative pregnancy rate. So the question is actually PGTA helping us or it is not helping us because of this biological misrepresentation, I'll say. So what is the problem with core term biopsy? What are we actually testing? This was a beautiful article by Joyce Harbour. And all of you know that a blastocyst is composed of around 300 to 200, 200 to 300 cells. And we are biopsying only 5 to 10 trophectoderm cells. So are they actually represent, do these 5 cells represent the whole embryo? The answer is definitely they do not. So a single biopsy cannot represent the whole embryo. I've given you enough reasons for, to prove my statement. For biological reasons alone, a 5 or a 6 cell trophectoderm biopsy cannot represent the whole embryo, and it can give a biological, misinformation. It can either lead to a mosaic result or a 100% aneuploid DNA, which is a misrepresentation. So this study by Gleicher et al., Norbert Gleicher, he said that at least 27 trophectoderm cells are needed to comment confidently on the diagnostic probability of a trophectoderm biopsy. Then if you take 27 cells, then you're likely to, represent the embryo correctly. But it is very difficult to take those many cells. Then you might end up damaging the blastocyst itself. Plus, another thing is self-correction downstream. That is, if the embryo is, growing into the blast implants, and there is some degree of self-correction which eliminates aneuploidy as well as mosaicism. So between day 3 and day 5 embryos, the mosaicism decreases dramatically, and as the embryo implants, the aneuploidy will go on to decrease. So human embryos have a ability to self-correct to significant degrees downstream from blastocyst stage, and mosaicism or aneuploidy, the likelihood of false positive diagnosis is very high. And also, some people have dared to transfer mosaic embryos and they have got excellent pregnancy rates. So, and disposal of false positive embryos after PGTA is especially harmful in women who are producing only few embryos. If somebody is producing few embryos, then you might weigh the cost benefit analysis. You should do a cost benefit analysis and then think of transferring and using the technology appropriately for them. So, aneuploidy may be physiological. Why do I say this? Because authors have compared aneuploidy in trophectoderm cells to aneuploidy in cancer cells. Now, cancer cells are also supposed to invade and implant, kind of, they are supposed to invade. And trophectoderm cells are also supposed to invade and implant in the endometrium. So they have got similar biological properties, and thereby the authors have compared aneuploidy to be more or less physiological. And in animal studies, they have seen that after implantation, you can't do it on a human being because you can't do it after implantation. But animal studies, they have sacrificed mice, and they've seen that aneuploidy has significantly decreased after implantation. So going by that theory, you at least we can transfer mosaic embryos. We'll come on to those studies later on in the presentation. So I hope things are clear till now. So we move on to the next slide. So this is a study which was published in New York Journal of Medicine, and it reported around 18 pregnancies in transfer of mosaic aneuploid blastocyst. So when you transfer mosaic blastocyst, the 18 pregnancies were reported, which resulted in 33% live birth rate. So people have done such experiments of. Sorry,
दूसरा मेंटेनेंस
you want to say something?
Kindly keep yourself muted. I think yeah, somebody's microphone is on.
Okay, I'm muting everybody then. Okay, can you hear me?
Yes, Dr. Sarpreet, we can.
Okay. So this study proved that mosaic aneuploidies do autocorrect as early mosaic embryos grow to blastocysts in utero, and very low level of mosaicism is reported in prenatal specimens. So moving on to the next slide, this was a study by Paulson, a landmark study. He proved mathematically that 39% implantations are lost because of PGTA and misreporting of mosaicism, and it can be technical, biological, or lab driven, the mosaicism. But again, we'll go on to study this in detail in the next few slides. If you now, second aspect is first was biological, second is lab induced. So any lab stress in terms of altered temperature, pH, osmolality, oxidative stress, culture media composition, it can lead to DNA damage, which can subsequently lead to spindle dysfunction. And any spindle dysfunction will lead to chromosomal missegregation, which will lead to aneuploidies and mosaicism both. So the lab conditions have to be properly maintained. You should not take anything lightly. So as Cairo consensus says that everything in lab is important. You can't single out that this is important, this is not important. Everything is important. So is there evidence that this occurs in human AVF embryos also? So this was a meta-analysis, and they went on to study the procedures. They tried to study ICSI, laser-assisted hatching, trophic biopsy, laser shots, culture media, temperature stresses, and pH instability and oxidative stress. So these few things they studied, whatever procedures are happening in the lab, and they found out that ICSI has no role in causing mosaicism, neither has laser hatching, nor trophic biopsy. Laser assisted hatching is different from laser used during biopsies. Temperature stress, yes, there is a theoretical risk. Culture media has a weak risk. pH instability, again theoretical, but oxidative stress is something which is possibly causing mosaicism. So, but no lab procedure has been conclusively shown to induce clinically significant mosaicism in human beings. So now the question is, how can laboratories minimize risk? So see, even if you don't conclusively know that they are causing it or not, but still the good idea is to keep the risk at the minimal level and follow best practices, stable temperature, strict pH control, low oxygen culture, minimize embryonic exposure, laser calibration, and standardized biopsy protocols, and a strict standardized quality assurance protocol and program running in the lab. This is going to minimize any iatrogenic damage or any epigenetic or genetic malformations. Now, coming on to something which is important, which is a topic for the day, that is the technological aspects or the technical aspects. We are using NGS, that is next generation sequencing, which is if you look at the protocol, it is doing whole genome amplification first, then a successive library is constructed, and with the help of sequencing and alignment of reading with the human reference genome, the reports are prepared. Now, DNA extraction and amplification is susceptible to errors along together with other methodological issues, making it very difficult to differentiate the true signal from technical noise. Now, this is again a technical flaw which exists with NGS. Also, inadequate stimulation protocols and suboptimal embryonic culture methodologies, increase in oxidative stress. I told you that oxidative stress can lead to mosaicism, and it can promote segregation errors, and this can lead to high degree of mosaicism reported in certain IVF units. So IVF units, PGTA also has different reports, and mosaicism incidence differs from clinic to clinic. So the kind of culture conditions they have, everything is important. And also the way NGS is reporting, that is, it is reporting copy numbers and intermediate copy number values which fall outside the range of aneuploidy, and aneuploidy are identified as putative mosaicism. Likelihood of mosaicism is there by testing laboratories and clinical practice. So further explaining this, the green is euploidy, whereas red, that is a 2 is euploid, and anything more than 2n plus 1, that is, or 2n minus 1, that is aneuploid. And anything which falls in between in this blue zone, it is known as mosaicism. So when the embryos, which they classified three categories, first was 20 to 80%. So anything with less than 20% was declared as euploid. Anything more than 80% was aneuploid. This second category, 30 to 70%. Anything less than 30%, euploid. More than 70%, aneuploid. The third category was a binary category, less than 50% or more than 50%. Less than 50% euploid, more than 50% aneuploid. And they found that by using these three different thresholds, the mosaicism rate went on to increase from 50-50 threshold to 20-80 threshold. Also, in the last group, the number of false positives were also more. That is, the conclusion was the specificity diminishes from binary approach, that is 50-50 approach, to 30-70 and to 20-80 range. So the specificity is going down from 98% to 54%, whereas sensitivity increased from 94%, 97%, and 98%. So, but you have to be more specific than sensitive. If you are not specific, then that obviously the degree of false positives is going to increase. So based on these results, it was found that a dichotomous approach is a superior strategy, and NGS intermediate results do not represent strong evidence of mosaicism, but an interpretation of collective data that is inconsistent with subjective arbitrary standards for aneuploidy or euploidy. So it was decided that a 50-50 or a binary or approach will be more beneficial. And there are some studies which have gone on to dissect this out further, and they have done rebiopsy studies on embryos which have been reported as mosaic. And they found that in case of mosaics, there is a very low correlation of trophectoderm with the remaining embryo. And this so this means the trophectoderm cells reported as mosaic poorly reflect the status of inner cell mass, and it undoubtedly challenges the reliability of TE mosaic compared to embryonic karyotype. And most of them, in a systematic review was done, and most of them, that is 57.4% embryos which are reported as mosaics, were unlikely to present as mosaics on rebiopsy. It's a very, very high number, and 29% were and 29 again 28.4% were turned out to be aneuploid. In another study, 4.8% cases diagnosed as putative mosaics was confirmed, whereas 42% came out to be euploid and 48% came out to be aneuploid. So in general, around 50 to 70% mosaic turned out to be 65% aneuploid. And if you take the case of 50 to 70% mosaicism, 65% were found to be aneuploid, and less than 50% mosaicism, 1% aneuploid. So that is the reason why we are taking the cutoff at 50%. And it was found that ICM concordance for segmental chromosome mosaicism was more than when the chromosomes were imbalanced in the whole chromosome. So that is segmental chromosome mosaicism is not that important compared to whole chromosome mosaicism. So if you take the case of whole genome amplification, which is a integral part of NGS, it's a major technical challenge, and it can lead to uneven amplification, and any uneven amplification will lead to some kind of mosaicism. There can be allele dropout, copy number variation artifacts. This is something technical. You just need to understand that there are some flaws associated with the technique which can lead to copy numbers being reported as mosaic. Any intermediate copy number will be reported as mosaic. We gave you the concept of intermediate copy number in the previous diagram. Coming to something which is most important for any clinician or any embryologist or any geneticist, that is how to interpret mosaicism in PGTA results. A broad diagram, which was commonly followed few years ago, euploid up to 20%, 20 to 80% mosaicism, and more than 80% aneuploid. But in the previous slide, we have showed that a binary cutoff at 50% works out to be better and more specific, though less sensitive compared to this model. So the ASHRAE also concluded that 50% cutoff is something which is more confirmatory, and it has to be co-evaluated with morphology. And they've also recommended prenatal testing. That is, follow it up with an MNU or a CVS during pregnancy, prenatal testing, sorry. If you look at what ASHRAE says that mosaicism has to be reported as low range or high range. That is a binary method. And the cutoff is 50% as per ASHRAE. And genetic TE biopsy cannot provide an absolute determination of mosaicism in the remainder of the embryo. Therefore, genetic testing should be designated as putative mosaicism, that is suggestive of mosaicism, not confirmatory. And a new stimulation cycle is not recommended with low range mosaicism. They are most likely to be euploid. And rebiopsy of mosaic embryos for the result for confirming chromosomal ploidy status is not recommended, and there is no evidence that it has got a diagnostic value. So these were the recommendations by Ray in 2022. Now, if you look at another guide, which is the PGDIS guide, and on transferring mosaic embryos in absence of alternatives. If you have got a euploid option, obviously you will go to a euploid option. But if you have got only mosaic embryos, then the guidelines are embryos with lower level, that is 20 to 40% of mosaic aneuploidy, are preferred compared to ones with 40 to 70%. And for embryos with higher level of mosaicism in the trophectoderm, there exists a high probability that aneuploidy will be present in inner cell mass. Such embryos will not implement with not implant. And in case it's a case of complex mosaicism, then transfer is not recommended. Also, trophectoderm mosaicism involving, so I think you should take picture for this also and the next one also. So please take a screenshot for this. Moving to the next slide. So the trophectoderm mosaicism involving chromosomes 1, 3, 4, 5, 6, 8, 9, 10, 11, 12, 17, 19, and 20 have not been associated with adverse outcomes, and these should be preferred to transfer. The low priority are embryos mosaic for trisomies capable of live birth, that is 18, 13, 18, 21, and 22. Trisomies associated with uniparental disomy, that is chromosome 14 and 15. These are all low priority ones. Trisomies associated with IUGR or intrauterine growth retardation, that is 2, 7, and 16. Now, these are the low priority embryos. These should be discouraged. Mosaic monosomies all seem to implant with a similar incidence to mosaic trisomies. So they contain trisomic cell lines also and shall be considered to have similar risk as compared to their counterpart trisomies. So take a picture for this. These are the recommendations. And always follow it up with a invasive prenatal testing after mosaic embryo transfer, not by NIPT, but by invasive prenatal testing. That is the recommendation, amniocentesis or CVS. This is again a guide of how to prioritize the transfer of embryos. Number 1, obviously, will remain euploid. Number 2, low-level mosaic. Number 3, high-level mosaic. Number 4, aneuploid if nothing is there. But they are not recommended for transfer. Again, a more elaborate view of the same euploid, low-level mosaic segmental, high-level mosaic segmental, low-level mosaic 1 chromosome, low-level mosaic 2 chromosomes, low-level complex that is more than 3, high-level complex, high-level mosaic 1 chromosomes, high-level mosaic 2 chromosomes, and high-level mosaic that is complex more than 3. This is a more elaborate view of the previous slide. So again, it was said that low mosaic embryos, that is, they 30 to 50% chance of being aneuploid, but they offer a 50% live birth rate, 8% miscarriage, whereas high mosaic 50 to 70% aneuploid embryos, 98% can be reconfirmed by rebiopsy, 98% lethal, and 87% risk of miscarriage. So these are the stats we have. So some people have said that we should not report mosaicism. We should either report euploid or aneuploid because it leads to poor reproducibility, variable thresholds, and it brings a lot of anxiety to patients, which I completely agree. So they've said the verdict from such authors is stop reporting mosaicism. This study, which was they tried to transfer aneuploid embryos, and they found that the chances of successful pregnancy with aneuploid embryos is close to 0, and these data can reassure clinicians and patients that aneuploid embryos are unlikely to result in positive reproductive outcomes. Whereas 11 live births were reported from 47 mosaic embryo transfers during the same period, which is around 23.4% live birth rate. Another study, these are all latest studies, not even published, and ahead of publication. I took it from editorial. And they, in this study, they kind of, segregated into a segmental chromosomal aneuploidy and whole chromosomal aneuploidy. And they found that all WCA, that is whole chromosome aneuploid embryos, resulted in 100% miscarriage, whereas the segmental ones reported in live births. Some live births, 48%. So this is just a comprehensive summary of what we have discussed in the last 30-40 minutes. So technical factors can influence results, which is TE cell lysis or damage during biopsy, which I explained you, the DNA leakage, low or uneven DNA count, which may be because of poor biopsy technique or a poor embryo, whole genome amplification bias, allelic dropout, PCR inhibition from culture media, sample mix-up, contamination, bioinformatics pipeline, and mosaic thresholds. If you look at, sorry, if you look at the technical versus biological mosaicism, technical, it can be due to lab or analytical limitations. It is usually low level and may not truly reflect embryonic status. Biological is the true one. Technical is the artifact. It results from mitotic errors in the embryo. I've explained it in slides. It may be high level, low level, often consistent chromosomal pattern, and it may self-correct as development progresses. So again, even if you have got a result, then there is a question that aneuploidies and mosaicism might correct downstream. So that uh, is something which is magical for me. Defeat science, actually, those kind of things. Potential embryonic outcomes can be euploid, low-level mosaic, high-level mosaic, aneuploid, or nowadays the concept is either you report aneuploid or you report euploid. The key takeaways from this lecture are mosaicism is real and complex. Interpret results with a lot of caution and context. Combine PGTA with clinical and morphological data. And the goal ultimately remains a singleton healthy pregnancy. So PGTA does not diagnose, it informs, and expert interpretation can change outcome. So that is where we need experts like Dr. Rajni and Dr. Fiona. And with this, I end my presentation. Thank you so much. And I'm open to questions if there are any. And Dr. Rajni, over to you.
Yeah. Thank you, Dr. Sarpreet. The presentation was very beautiful and elaborately discussed also. And very, very beautifully, you touched upon all the factors which are important in terms of reporting and interpreting PGTA and mosaicism. Now, I would request all the audience to, I cannot see any questions in the chat section, but I would like anyone who has any question to unmute yourself and ask your question or write
Dr.
it down in chat.
Dr. Rajni, hi, good evening. Dr. Nisha here. How
Hi,
are
Dr.
you?
Nisha. I'm fine. Dr. Nisha, how are you?
You're
Dr.
looking so young.
Really? Thank
सब
you.
anti-aging हो रहा है ना?
AI.
Hi, Dr. Sarab, how are you?
Very nice, ma'am. आप बताइए.
Thank you so much. Ma'am, I had a question. So many times we get a report from the lab saying that no DNA detected.
Yes.
Now, no DNA detected, usually, what are the options we have? First of all, I want to know, is it because of the biopsy being performed by, is it an embryologist fault or is it an embryo fault or is it just a simple error at that point of time and a repeat biopsy will solve that problem? Because so many times we see that this no DNA detected report is usually coming from a 4BB or a 3BB embryo. So what should be the where is the problem and how can we sort that out? That
Yes.
is my one question.
Yes.
And second question to Dr. Sarab, he rightly pointed out that so many changes in the lab can lead to mosaicism and problems in the embryo. So though we maintain all KPIs and all, everything is sorted, but suppose we detect a high aneuploidy rate, is it like we, other than the KPI, is there something specific we need to check? Or is it because of the lifestyle changes the patients are having nowadays and age factor?
I think
Great question, Dr. Nisha. So I would like to answer your first question and then I will hand over to Dr. Sarpreet. So regarding your question for no DNA, see, there are multiple factors as you stated well that it can be that your embryologist did not took the right amount of cells because generally we say that we should have at least 5 to 8 cells or maybe 5 to 10 cells. So in case the number of cells are only 3 or 4, we can end up having less DNA and that can give us a low DNA input. Another thing can be that when the biopsy is taken from a low grade embryo, okay, and then even if you have 5 to 6 cells or 7 to 8, sometimes the nucleus or the nucleus is degraded in those cells, and maybe the DNA is fragmented. So when we amplify those cells, we do not get a good amount of DNA from those cells, and that can lead to no DNA detected again. Another reason is again when the person is taking the biopsy, okay, and even putting the laser shot before taking the biopsy, it is also evident and reported in multiple studies that giving too many laser shot to the embryo can also lead to degradation of the cells around the laser shot, and when you are taking the biopsy, it may also lead to either a lot of aneuploidy and also can lead to a less DNA also. And these are the major things which lead to no DNA detected. But yes, again there is another factor. If you are sending your sample to a lab which is not locally placed but is placed at a different city, then it takes a lot of time to reach over there. Sometime during transportation, if your cells are not frozen and they are in a kind of room temperature stage, what happen that during transportation the cells can keep on moving and they become fragmented. That is also another reason where we may end up having a low DNA from those cells when we receive the biopsy. So transportation is
Right.
also important. So that's why
Yeah.
it is very important when you are choosing a lab, you need to choose a lab which has a validated transportation system, or a locally available lab, again a validated lab. And also your embryologist should be skilled enough to know all these variation that can lead to these aspects. And I think once you have all these things, the chance can be reduced. And in case you see a lot of same kind of scenario coming up, definitely there is something to talk about with the lab, because it can be something related to lab also, that whether they
Great.
are doing it
Great.
rightly or something is wrong at their end.
I know it's like there cannot be any parameter to, because we are dealing with different groups, so there cannot be a KPI that 50% will be euploid, 50% will be aneuploid or something like that. But still, I mean, that is rightly pointed out that maybe we can keep a check on which embryologist performed and that those kind of thing. Great, thank you, Dr. Rajni. Thank
Technician
you so
should
much.
always remember that if the lab is good, generally the rate of no DNA detection should be anywhere from 0.1 to 2%, not more than that. If you are
Okay,
getting too much, that means something to worry about.
okay, great. Thank you.
But you should be having that many samples to, report it as 0.1 to 0.2%. So somebody who is doing like sending
Yeah,
10
yeah.
cells, so it difficult to get that kind of calculation. It might be,
No, we did,
a
Dr.
higher
Rajni.
percentage, but
We did
yeah.
that
Yeah.
in the early time when, so it can happen only if you are sending it to one single lab,
Yes.
and that's how you can do a follow-up. If you're sending only one to different lab, then you cannot do that, because that way you will not be able to have a proper validated follow-up. So that's also important.
The one thing what I was just thinking is that what exactly do you do? Like you multiply the DNA, whatever 6, 8 cells you have got, so you grow that in culture and then you
No,
detect maybe.
no, no.
No.
So
Okay.
basically, if you have you put the cells in a small tube, okay, that tube comes to the lab and everything goes into the same tube. The sample is
Okay.
not moved. Some chemicals are added onto that cell, those cells, which increase the amount of. So finally, what we have to do, we have to break the walls of cells and get the DNA and the chromosome come out, and then from chromosome, you have DNA. We have to lyse that, and then we have DNA quantity, and then we put on some chemicals which extend the number, or exponentially increase the number of DNA in that tube from like from 1 to n number, so which gives us
Yeah.
an increased amount of DNA.
Okay.
So that's called
Thank you so much.
whole genome amplification.
Yeah. Okay. Thank you so much.
My pleasure.
Dr. Nisha,
Dr.
what was your second question?
No, I just wanted to know from you that if
Partly
we
covered, yeah.
specifically see that there is increased euploidy or something there, maybe we need to keep a record or keep a like what checks we can do in our lab to, other than the standard KPI. Is there a specific KPI which deals with euploidy which we can check?
So, I think all you can check is, the biopsy, if there any is there any amplification failure happening, because there is something wrong with either the biopsy technique or the tubing technique. And then,
Okay.
depending on if there are a lot of amplification failures which are happening, you have to focus on these two things in your lab. I think that's what the embryologist can do. He can biopsy well, select the embryos well, biopsy well, and tube them well, tube the cells well. Rest all depends on the genetic lab, how good the transportation is, how nicely they are amplifying. So there are two different set of things here. And if you feel that the no amplification is increasing, you can only focus on these two things as far as the
Okay.
IVF lab or the embryologist is concerned.
Okay. Okay. Thank you. And I really want to congratulate you, Dr. Sarab. It is really so many interesting sessions. I think every session we are learning so much. And every session tempts me that I should join the academy for the further lecture, for the further lecture. Thank you so much. You're doing a wonderful job. Thank you so much.
Thank you, ma'am. All thanks to our stalwarts like Dr. Rajni and I mean everybody who in our team is a stalwart. So
Yeah, yeah, I agree. Totally
management
agree.
and
Dr. Rajni is great.
yeah, we are offering the our faculty invitation to you also at this moment.
Thank you. Thank you so much. It's great to listen to all the people. Thank you so much.
Yeah. So, any more
Hello.
questions? Yeah. Yes, ma'am.
Yes.
Yes. Please
Yes.
go.
I've listened with difficulty, but it's very interesting. At least I have one or two things I've learned to talk to my geneticists about the um, mosaicism he reports 30%, and tell him that no more mosaics. So it means we're going to transfer all mosaic embryos, or we must wait for it to be more than 50%. I need to know. And then you also said some chromosomes 1, 3, 4, 5, 6, 8, and so on are allowed, whereas the other ones are more deadly, so to say. So my take home is that I would tell him to be, the embryologist to be careful about the ICSI, the laser, the temperature changes, the pH, and all that. So I want, and the oxygen level culture. I want to know what to do to mosaics and whether to transfer them, despite irrespective of the percentage, and then pay attention to gross aneuploidy. Thank you.
So I must congratulate you, Dr. Aguilar. You picked up very pertinent points. So one thing I like to highlight here while I was listening to you, that too many laser shots, though it's a low heat, low intensity, very short, I mean heat wave, but it can increase aneuploidy if repeatedly shots are given to the trophectoderm cells. So always limit the number of laser shots for all embryologists. Maybe we used to work with 3 to 5 laser shots, and then a good flick method. Even if flick method is not good, that can also lead to embryonic stress and can lead to aneuploidies, or these things can simply damage cells also. You've done a biopsy, everything is reported, but too many laser shots, improper flicking method can lead to everything going waste for the patient, because the embryos may not survive. So coming back to mosaicism, I feel the X-ray method works fantastically well. I've presented a lot of literature of how the specificity and sensitivity and the false positive rates, they change if you when you move from 20 to 80% bracket to 70 to 30% bracket to 50 to 50 bracket. So I think X-ray also recommends, I would like Dr. Rajni's opinion on that. Ashray also recommends 50-50 as the 50 as the cutoff. Anything less than 50% is euploid. Anything more than 50% is aneuploid. Very thin line between a 48% and a 52% also. Along with that, take into account the morphology, the mito score, and the patient factors, and then you decide how do you interpret the results and which embryos you would like to transfer. Dr. Rajni, your opinion on that? Dr. Iguilo has raised very nice points.
Exactly. I agree with your discussed point, Dr. Sarpreet. So that in embryology, you have to control all the factors related to laser and your method of biopsy, and you have to give less stress to the embryo because all these lead to aneuploidy rate and increases that. And also, in regard to percentage of mosaicism, yes, I agree that Although I don't know nowadays, every lab has their different percentage if you see on their report, but we still follow the ASHRAE percentage that anything below 50 is chosen as a low level mosaicism, and anything above 50 to between 50 to 70 is considered as a high level mosaicism. So if it's low mosaic, definitely you can, when you got a report and you have a low mosaic, and you have to see the number of chromosome, which chromosome is involved in that mosaicism, whether it's one chromosome or number of chromosome is two or three, or also which specific chromosome, like for chromosome 13, 18, 21, they are considered high risk chromosomes, and 16, 22 also, 1, 3. So it is mentioned in those guidelines. I think everybody should look at those guidelines. There are multiple papers related to guideline to make them understand which chromosomes are risky chromosome and which are not risky chromosome, so that they can transfer based on that. So there are multiple factors we have to look at once we get a mosaic report, and we have to counsel the patient with all the aspect, giving them very transparent information what does it mean, so that they can understand and then they can choose the transfer accordingly.
Thank you.
Thank you.
Can I ask a question?
Yes, Dr. Ajay, you can ask.
So I'm Dr. Ajay from Kathmandu. So I have met Dr. Sabarjit in anatomy conference. Excellent talk about this mosaicism, sir. I got to know so many things. I have one question, but before that questions, I just wanted to say, like, during in my IVF also, I have transferred many mosaic embryos, and then I have got like healthy, pregnancy. And even like the previous speaker said, the low DNA content in many, like we send to the sample, and then some of the sample shows the low DNA. So we have used that the embryo, in case of there is no euploid embryo. So we have also got like successful pregnancy by using this low DNA content embryo. And regarding my one question, it's a query, not question actually. So yes, it's a, if it is in the mosaic, the embryo autocorrect itself, right? So this, I have a question regarding an autocorrection, a technical question maybe. Is there any known, like the autocorrection means the mosaic part of the embryo or cell itself the correct, or it degrade, that cell itself degrade, and only the good cells, the euploid cells grow and make a child, and then the bad one goes off, or the bad one also autocorrect itself. Is there any article
It's
known?
like, Dr. Ajay, there are a lot of animal studies which say that the aneuploid cells are apoptosed. They are, kind of, it's a natural selection, and apoptosis happens in with
Yeah.
aneuploid cells, and the euploid cells, they kind of persist. Dr. Rajni, your views? I mean, there are a lot of animal studies which say
Yeah,
that.
yeah, it's a good question, Dr. Jaya. There is a recent paper on that also. Maybe you can read that. So generally, it is so they have speculated different kind of theories. So these are all theories, proposed theories, not a really evident method. So they propose the same thing which you are saying, that one survival of the fittest, that which one, the one which are good cells, they stay, and the other which are not good, they just degrade. And also there is a another theory that the euploid cells, they just increase their number exponentially than the low grade cells. So that's another way. So this way they have proposed three or four theories, but it's not clear that which one is the correct thing. But yes, auto correction is there, and that's what, when we counsel the patient, we have to tell that also, that auto correction happen. So we can't be sure that definitely uh, the the embryo is going to be completely normal or not, because the kind of biopsy we are taking and the result we have to be we can't be 100% sure in saying that the baby will be completely healthy.
Okay, thank you. May I ask one more question again?
Yes.
Yeah, please.
So during this mosaicism, as you said, the guidelines, the chromosome like 16 shows IUGR, and then 1, 3, 5, they show like less complications. So I
Yes.
also like get confused because if you have like certain chunk of the P chromosome of the 5, it shows it can show like the Cridusa syndrome, the baby with the
Yes,
cat-like syndrome.
yes, yes,
So, and that guidelines also says like safe for even the mosaicism X and Y, but
yes.
for 5 and X and Y, I'm always cautious to transfer. So, and anything any light on that?
And no, so Dr. Ajay, so I think if you have these paper, they have very
Yeah,
clearly, so they have categorized into five categories, okay? That this is a high priority to transfer, this is a medium priority to transfer, and this is a low priority to transfer. So, and over that, as I said, that the kind of biopsy, we know that we are not taking the whole embryo for testing, we are just taking a small chunk, and that too is dependent upon the embryologist who is taking the biopsy, whether how the laser shot is given. A lot of factors are involved. So even when we get a mosaic result, we can't be sure whether that's a true result or not. But yes,
yeah, that
taking a chance. Many time it can happen that the patient has the only choice of one single embryo where the patient may have a chromosome 13 low level mosaic or chromosome 21 low level mosaic sometime,
yeah,
and they cannot go for another cycle, they don't have a chance, so they can even take a chance with that, knowing everything that it may end up in miscarriage also, it may end up as a live birth also, but they have a possibility of doing prenatal if the pregnancy move forward from early trimester, so they can do amniocentesis and check whether the pregnancy has abnormality or not. So I
yeah,
think
yeah.
that's
I
the
agree.
best way to guide the patients, even when you have a very high risky mosaic thing and patient doesn't have any other options left.
Okay, thank you very much.
Yeah, my pleasure.
So I don't see any more questions in the chat box. If you have any questions, you can ask live. Another thing, tomorrow our course starts, and today is the last date for registration. So if anybody is interested in the reproductive genetics course, which is run by Dr. Rajni and Dr. Fiona primarily, and a couple of lectures I'll take. So if you're interested, today is a good opportunity to register. Dr. Rajni, any concluding comments from your side, and then we conclude because I don't see any much questions now.
No, Dr. Sarpreet, I think we have covered everything, and there were a good number of questions also, which people must have got an idea. So, still, in case anybody has any question, I think you have Academy's
Yeah.
email. You can send us those queries, or maybe
Yeah.
write down on the WhatsApp group because we all are there and we can answer that also.
Yeah. You can
So,
put your queries in the demo groups, and
yeah,
we'll be more than happy to answer.
yes.
Yeah. Thank you so much. With this, we end the session, and thanks for attending.
Thank
Good
you,
night.
everyone. Thank you for your time. Bye bye. Have a good day.
Good night.
Thank you, sir.